Good afternoon, everyone. Welcome again to our Patient and Family Education webinar initiative on borderline personality disorder. Before we get started, I've got a few logistical announcements to make. All of your microphones have been muted, and other participants won't be able to see your name or email address in order to help you maintain your own confidentiality. But we hope and expect that all of you want to participate. Tonight's webinar with Dr. John Gunderson is really going to be primarily open format. And we're really looking for you to guide us in terms of questions and content that you're interested in. So starting right now, if you have specific questions or areas that you'd like us to address, feel free to use the question and answer box in the lower right-hand corner of your screen and type in any types of questions that you've got, and we'll get to as many of them as we can. But again, I want to remind you your microphones have been muted, so you won't be able to raise your hand, you won't be able to speak with other people or directly speak with us, but you can communicate with us through the Q&A box. We have other webinars already lined up. There's a webinar for February 3rd, next month, featuring Dr. Mary Zanarini, and she'll be speaking with us on the long-term course of borderline personality disorder. So if you'd like to register for that webinar, you can click on this link in your lower left-hand corner, and you can register right now, or feel free to come back and register at any time. And I think with that, it's my pleasure to introduce tonight's speaker, Dr. John Gunderson. So for those of you who don't know him, Dr. Gunderson is a professor of psychiatry here at Harvard Medical School, and he's really devoted his career to work with borderline personality disorder patients and family members. He's done quite a bit of research on it, quite a bit of teaching, and also writing seminal books on this. His work helped transform the diagnosis from a psychoanalytic construct into an empirically validated diagnosis and disorder. He led the DSM-4 task force on personality disorders, and so really was instrumental and a leader in terms of refining the diagnosis of borderline personality disorder and other personality disorders. So again, tonight's presentation is really open format. He may have some introductory remarks about some common challenges that family members face, but we're really looking for input from you. So if you have questions or if you have specific topics that you'd like us to discuss, feel free to type them in, and we will get to as many of them as we can. So now I'd like to turn the webcam over to Dr. Gunderson.
Thanks, Chris. Hello out there. As Chris suggests, I've been here thinking about treating, teaching, doing research about borderline personality disorder for over 40 years. And I was one of the people who, well, I guess I was the primary person who wrote the criteria for this disorder, which remain relatively unchanged to this day. So I've seen a lot of changes and participated in most of them. And we welcome fielding any questions you have about the disorder as best I can.
So Dr. Gunderson, you ready for the first one? All right. So we've got a question from a parent. Do you have any thoughts or advice about how to get a young adult child with BPD to live independently without leading them to act out?
That's a very, couldn't I get a little easier question to start out?
No, I'm going to give you really hard questions.
that's a project. It's not one thing, and it's not short term. Many people with this disorder have an undue dependency on their families of origin, and the reasons for that generally extend in two directions. One is their fears about the separation from their families, where they may feel they are protected or sheltered, or where they fear that if they're out of sight, they'll be out of mind. That's the backward view. And then the frontward view is that they fear that they won't succeed if they enter into the outside world of competition and sexuality, and for which they feel ill-prepared. Now, to address both of those things, is not a simple chore. Talk therapies are useful for sure. The conflicts about leaving home and with the parents or family, that's also something that can be addressed, sometimes by talking with and advising the parents, even in the absence of their reluctant to leave child's participation. And sometimes with the participation of the young man or woman themselves. That's about what I can say about that. It's pretty complicated question.
Okay.
Oh, I should add one more thing. That there's a lot about this disorder which is sort of developmental. And if you don't do harmful things, like become too overprotective, or threaten to kick the kid out, most of them will find their way out with time. So support and stability is a very good thing to hold on to. So that doesn't mean you shouldn't seek some help.
Okay. So we're getting into some issues that have been recurrent themes over the last several webinars. So on that topic, could you help people differentiate between enabling and support? So I think some families have a daughter or son diagnosed with borderline personality disorder who've been ill for years and have really become what some of us call chronic patients. And their identity really centers around being a patient and less around functioning in a job or as a student or in relationships. And a lot of families have, I'm seeing a lot of questions today, and I've seen a lot of questions over the course of these webinars of people really struggling with what do we do if we have a daughter or son who has become kind of a chronic patient and their identity really is around being a patient. And are we really helping them by paying for their living expenses, by paying for their therapy, when they don't seem to be really becoming more functional and developing a life of their own? And I think a lot of family members are really struggling with that question. Are we helping? Are we enabling? Are we actually hurting them by doing all of this? And how do you make sense of that? Or how do you think about that?
Well, again, a very complicated question where there's differences from one family to another is a good question to raise, first of all, because it is very possible and not unusual for families to get beaten down or held hostage by a borderline offspring's threat that they will hurt themselves if they are pushed out of the nest. On the other hand, it is not good for them, and it isn't good for a family to shelter somebody from that expectation that they need to get out. There are guidelines which have been written which help facilitate this. Amongst them are the principles that you go slowly, that you do not forego family routines in the service of the caretaking of the kid. If your household becomes like a hospital, that's time to seek professional help for sure and transfer the care of such things as suicidality into the hands of professionals. That's not something that can and should be taken care of by families. Just the process of doing that is a step towards disentangling yourselves from the child's dependency on you and your living under the shadow that you can't expect things from them without precipitating something harmful. It's oftentimes simple enough that parents don't want their kids to be angry with them. And that is a psychological handicap on the part of parents that can be addressed without ever involving the kid. It's dangerous for the kid if they feel that they have so much power that they can injure or break a marriage apart by behaving in unsatisfactory ways to their parents. So if the issue is that your kid lives at home or is not moving on with their life, in part because they feel that you, the parents, need them, or because if they get angry, you buckle and give them whatever they want, then you become collusive partners in this chronicity thing. And again, counseling for you, the parents, can be very helpful for that.
Okay. The next question, we've had a couple of people ask about siblings. So this question comes from parents who have more than one child, and one child has BPD. And their question is, how do we talk about this with the siblings? A couple of people have noted the siblings hate in both of these cases, it was a woman with borderline personality disorder. Siblings kind of hate her. They're tired of the drama. They're tired of everything. And as parents, how do you think about that? Any suggestions for what you could share?
Well, first of all, again, that is not unusual. And specifically, siblings become resentful when they see the parents devoting a disproportionate amount of their time and availability, money, and to the sibling with borderline personality disorder, who they see as being entitled and exploitative and taking advantage of the parents. The first thing to do there is psychoeducation. It is very difficult, not only for siblings, but in the first instance for parents, to recognize that this is a disorder where the demands that the child is placing on the parents are not simply being a willful, spoiled brat, but are symptoms of a disorder for which the kid is suffering and for which nobody would voluntarily seek for themselves. People with this disorder suffer a lot. They are ostracized generally within their social communities. They place demands not just on their families, but other people, which are offensive, so that they end up very isolated. And seen through that light, the disproportionate attention that's being given to them is more like something that is a burden that the parents must uh, uh, undertake for the care of their kid, for the care of a responsible kid, and not something for which it is uh, permissible to simply blame the sibling for being, you know, willful. That's easily said. That is not easily done. For a long time, the clinical world that has surrounded borderline patients has been offended by them. This is a disorder that Time magazine once wrote an article about as being the disorder doctors least like to treat. Not just psychiatrists, but doctors in general. And that's related to this. These are people who offend even those who are paid to take care of them. And it takes a lot of perspective to step back and sort of see the demands they're making as part of the problem. I think that the interpersonal demands that borderline patients make are the essence of their problem, not, and certainly a major symptom which characterizes the reason that they have all the difficulties they have in their lives. So when you're the subject of that, that is, you feel neglected, overlooked, selfishly and insensitively forgotten, remind yourself that this is a sibling who is seriously impaired in their ability to make it in the world and seriously impaired in their ability to make relationships with anybody else too, that they're very isolated by these problems.
Good. Dr. Gunderson, several people have asked about the dilemma of dealing with a loved one. In this case, we have somebody with a daughter, another person who has a sibling with that he suspects has the disorder. And these people don't want treatment, they don't see a problem, or they clearly acknowledge there's a problem, but they're not engaging in treatment. Parents go out of their way to line up therapy, and then the person just doesn't go, isn't working, isn't going to school. Any general thoughts or helpful hints about if you know of somebody with symptoms of borderline personality disorder, but that person's not getting treatment?
Well,
how can you be helpful?
I'm just involved with a family where that situation exists, and the clearest thing that this family could do is diminish their contacts and their welcome to the patient. That is, it's one thing if the patient is out in the world and not causing problems within the home. But if they're causing problems within the home, you can set limits on your availability and your tolerance of that. And it's a good thing to do. In this instance, I told parents that they should not initiate contacts with their son or see the son until he has made some efforts to get into treatment. Now, having said that, this is a son who adamantly refused to be in treatment and is disdainful about it. And when somebody has those attitudes, the likelihood of their using treatment is not very good. But the motivation to change, not to accept a diagnosis, but to change their behavior, can start with the family being very clear, not just in words, because words won't count if the person has borderline personality disorder, but in actions, that their behavior is intolerable to you. Set limits.
And so you think it's important to set limits around specific behaviors?
Your availability.
I guess I just want to clarify because I think some people's inclination is to kind of yell at the person and say, "You have borderline personality disorder.
Not
Wake
use
up, smell the coffee,
books.
go get
Not use
help.
books.
Here's
Yeah,
a
not
book."
use- Well, sometimes reading a book can be helpful, but certainly not a book that's given in anger. A book is given because reading something may be more acceptable than being told something by a family member. With the idea that they should read this and see whether it makes sense or whether it applies to them. Making them a participant in the diagnostic process can sometimes be, well, certainly the most useful way to get past some resistance to the particular diagnosis. You don't assign it, you ask them to look at the criteria, see whether it fits, and then let them know. Hopefully you won't do that until you yourself know that this is a diagnosis for which there are some reasonable treatments and there are reasonable expectations of change and improvement with time. So it is not what they might otherwise get out of a website, that this is an intractable disorder for which there are no good treatments. It's quite the opposite. It's actually a pretty good, if you have to have a major psychiatric disorder, this is a pretty good one. Remarkably, given all the pejorative things which the previous generation, including me, wrote about their prognosis.
Do you have thoughts about the family member or loved one who isn't living at home, but your family member, you stay connected every now and then, and you continue to hear the drama, or you continue to hear about the suffering, and the person just doesn't get help? Any thoughts? Because disconnecting from them.
This is off.
It's actually still recording you. Sorry.
Okay, sorry.
Any thoughts about how to be helpful to them, or even a framework of how one might approach that person to encourage them to get help?
This is a family member who does not live at home.
This is a family member who doesn't live at home that you're not supporting.
Yeah.
So especially, I'm assuming, especially in the case of a sibling, that the sibling is just authentically concerned, but probably is not in a position of financially or otherwise supporting the person.
You start out with what not to do. That's much easier, which is you don't try to push it down somebody's throat. You let them know that you have read some things which made you question whether this was a disorder that might fit them, because if it does, there's some pretty good treatments available, and that they should, in any event, know about it, because there's a literature about what the future is likely to hold for them, and what the implications are for their children if they have them, and that it's just a disorder which, if you have it, you're far better off to be well informed, and then leave it up to them where they go for it. So you don't say, I really think you need treatment. That's generally not a message which people with this disorder will welcome, however well-intentioned it is.
Can I offer maybe another option for those who maybe are looking for even more concrete advice? What do you think of the option of the family member or loved one simply saying, I'm so sad and sorry to hear that you're still suffering, or that you're still having this problem, or that you're still having the thing. I wish I knew what to do to help you, but I don't.
That's a very good start.
But I think there might be treatment available if you're ever interested in getting help.
If I had, that's the guy you should be over here. Oh, that's very good. It's very good.
Okay. A couple of people have asked about the comorbidity of borderline personality disorder and addiction.
Yeah.
One person asks if you could just speak generally to the topic, but another person pointedly asks, how do you ask a child with borderline personality disorder and addiction to leave home? Because the problems are getting to be a little too much.
Well, let's talk about the problem first. About 30% of people with borderline personality disorder have serious problems with substance abuse. When they are dependent upon some drug or substance, they're not going to be able to use treatment for borderline personality disorder. If they have an intermittent substance abuse problem, where, for instance, they get drunk when they are feeling rejected, that's something that can be integrated into the treatment for the borderline personality disorder. Otherwise, though, if it interferes with their thinking concentration, they're preoccupied by where the next drink is going to come from, that's got to be addressed, and there needs to be a period of sobriety before they'll be able to use treatment for borderline personality disorder. With respect to how to help somebody, it's not unlike what we just talked about in many other forms, which is, I like what you did, Chris, a minute ago. You start out with expressions of concern, that you feel concerned about their welfare and you feel somewhat helpless about it. And then secondly, you provide them with the ways to learn about this disorder, or ways to read about how these disorders affect each other. So you encourage them to get a psychoeducation about it. Or if they don't want to do that and they're interested and you know enough, then volunteer it. Or if you don't know enough but they're interested, have them see a professional and sit down and get an overview of the sort that I just said, that, the borderline personality disorder may be the parent condition, the primary condition, if the substance abuse isn't too severe. Then you want to get the borderline personality disorder treated. If the substance abuse is so severe that it's interfering with one's abilities to their social adaptation and their concentration, then that's got to get taken care of. And there's, you go directly into the substance abuse treatment world.
Okay. Any thoughts about the parent who's struggling with any advice on setting the limit and asking the person to leave home? And I think it raises a broader question, not just on addiction, but you had said a little bit ago that if the person's refusing help, that you might need to set limits. And one of those limits, I guess, in an extreme case, after probably many months of trying other things, one of those extreme things might be asking the person to leave home. Yeah. And given that suicidality and self-injury are such common concerns for parents, any advice for parents on how to manage that? Like, are we going to push this person over the edge? Is she or he going to attempt suicide because
it
we
is a
kicked them
very
out?
difficult thing to do, to set that limit. You have to leave one's house. And you don't want to do it under circumstances where you're concerned that they're going to seriously hurt themselves. seem realistic. So assessing how realistic the danger is something that is hard to do by yourself. And it is good to get professional help in looking at that. And when you talk with professionals like ourselves, we often look at the history. Has this somebody been somebody who's made serious suicide attempts before? Many people with borderline personality disorder make minor serious suicide threat, often make suicide threats, many times make what are modest suicidal or self-destructive behaviors, but they're rarely life-threatening. And with that history, I'd feel more emboldened about setting that limit about leaving home. If, on the other hand, you have somebody who has, on several occasions, driven their car into trees or overdosed in a way that could have been lethal, then setting that limit would be too dangerous, and you might have to, at that point, see whether the person could be institutionalized. And that in itself might be the only way in which they can separate from the house. Because if they're held hostage, you held the family hostage by this threat, it's just a terribly destructive thing for the parents and for the kid. Let me cite a variation on this where I may have made reference to it before. A kid can feel that the parents need them so much that the parents can't set a limit on them. And they will, for example, use drinking as a test model, that the parents say you can't drink, it's not good, it's dangerous for your health. And then, but when they're home, they always drink. Just begging for the parents to set a limit on it. And the only way the parents can set a limit on that is say, well, you can't come home, you must get into treatment, and you cannot be at home and do that here. Well, that can be a very powerfully positive thing for the parents to set a limit under those circumstances, where it's not immediately life endangering, and where their ability to forego what their own wishes, which is to have the child come at home, to sacrifice their own welfare on the basis of what they know is the best thing for the kid, can be a very powerfully good thing to do. Very difficult even under those circumstances. But it is possible for, it is unusual, but it is not rare for people who develop this disorder to have become so important to their kid, to their parents, that the parents would rather have them at home than to have the kids be angry with them.
So moving on to another topic, a couple of people, it sounds like, are in need of a little hope. One person asks, will life always be a roller coaster for family members dealing with this? Will they ever be at peace? Another person asks, if treatment works, how long does it take?
Yeah. Well, when you're in the midst of this, and oftentimes people who ask those questions have been in the midst of a kind of turmoil and alienation, and that has extended for a number of years. When that happens, you have to ask yourself whether the family is participating in this. And definitely seek some help within the family, regardless of whether the borderline offspring is interested in it or not. The natural course of this disorder is that about 20% will remit, meaning they go down below a couple symptoms criteria in a year, about 45% by 2 years, and then it goes up to about 85% by 8 to 10 years, and that once people remit in this, they stay remitted. The speaker next month, Mary Zanarini, has authored the major studies in this area, and we'll be able to expand on that. But when most of these people get better, they do not do it in weeks, they do not do it in months, but they do get better, and when they get better, they stay better. And with respect to the family turmoil, that addresses that issue for the most part. What it doesn't address is whether their son and daughter has a happy, satisfactory life. Because the people stop cutting their wrists and they stop having rages, then they settle into some kind of social network where they're stabilized. They do not as readily get stable, close partnerships and satisfying employment. So their lives are stable, become stable. They are not the source of the tearing out your hair and midnight emergencies that the disorder starts with. But they're not also, for the most part, healthy, happy people. Having said that, there is a significant minority who by 8 to 10 years, like 20 to 30%, have fully recovered, where they have more than had symptom reductions, but they have both stable partnerships and or stable work, and that percentage rises after that, as Mary, my colleague Mary, will talk about next month. So it's a longer term process. It's one where you should not despair. If you are the parents of one of those children whose course does not seem to be improving, that often is a situation where there are factors within either the family or the living situation which are stimulating or encouraging the continuation of the illness. That's not, and then, so it isn't as if people are hopeless. Hopelessness does gain power with years and years of this. The longer you have the disorder, the more despair sets in on the part of the people who have the disorder. And often enough it's a silent despair, but sometimes the risk of suicide actually increases with chronicity.
So Dr. Gunderson, we've got a few questions about treatment, and I'm going to start with maybe a broad overview. So when you talk about treatment for borderline personality disorder, could you tell us a little bit more about the range of options and what types of treatments are you referring to? And if somebody has a loved one with BPD, what types of treatments do you think they should be getting? Because they might see a psychiatrist who puts them on an antidepressant and says you're good to go, and yet the person's still having symptoms.
2% of the population, that's many millions of people in this country alone, have borderline personality disorder. 20% of the people who seek psychiatric care in hospitals or clinics have borderline personality disorder. There is a huge number of people who need help. The training of clinicians who are able to serve them well has been very slow and is still only now developing. And this part of my career, this is what I'm primarily dedicated to doing, which is changing training programs so they incorporate a curriculum which addresses the basic needs of these patients. It's not existed until now, despite what I say, 20%. There is no mental health professional who can avoid working with these patients however much they might want to. And these patients deserve to have clinicians who are trained to provide the basic necessities of their care. So while the simple answer to that question that I might have given 10 years ago is that there are these specialty treatments by specialists who have received extensive training that offer a great deal of hope for borderline patients. What that answer would ignore is that those treatments are not available to all but a relatively few consumers. The vast majority of consumers need to look for something more attainable. And what you would want in those circumstances to have people who have experience working with borderline patients, who are not frightened by it or dislike people with the disorder. Those are sort of basic things. Because if you get clinicians, and you use the example of a psychiatrist who prescribes antidepressants, antidepressants don't do much good, but a psychiatrist, whether he prescribes the antidepressants or some other medicine or nothing, can have a really major role in the care, in the future of patients with this disorder. It's good enough for the majority. Many, many people with this disorder benefit far more than we ever imagined from the stable presence of somebody who cares about them and who has good judgment and helps them with the problems in living that they're encountering. And I even need to be a psychiatrist. So the background training of psychiatrists, I think, has some advantages because we're used to case management. And we have a certain authority, and we have built-in readiness to tell people what we think is right about and wrong for them, and that's very valuable. Psychotherapists are a mixed group. That you can get experienced psychotherapists, but many psychotherapists who have been trained primarily with the psychoanalytic model are likely to be harmful, because what they will do is be reluctant to give the activity, the feedback to these patients, which these patients require. A passive therapist who simply listens is not going to be helpful. So you are alert to that. You're alert to those therapists who are simply doing support. If you simply do support, it is likely to be discounted and people will like it, but it's not going to involve any sort of helpfulness in terms of getting on with their life. So this is a rough answer. There is a new type of therapy, evidence-based, which is called like good case management, good psychiatric management, but it's the same for good psychological management or good social work management, which does just about as well as the premier evidence-based treatments, DBT, mentalization-based treatment, and transference-focused psychotherapy. And that's the level at which you want to start. You want people who've had basic training and who are interested in working with this group of patients. That's becoming much more available, and that's where you should start. If that doesn't work, then you kick it upstairs to the experts.
Okay. So on this same topic, any advice for family members who feel that the treating clinician maybe isn't doing the right thing? So one person specifically asked, my son was seeing a psychiatrist who reduced the time he sees him to once a month. I don't feel that's sufficient treatment anymore because my son is still disconnected from his feelings. He's isolating himself from friends and activities.
Yeah.
What should family members do when they think that the person might not be getting optimal or appropriate treatment?
Optimal is, like you don't need a Cadillac for the most part.
Okay.
But a person with this disorder should get better. That's the natural course of this disorder, is that people get better. So if somebody isn't improving, get a consultation. And if they're getting worse, then you get the consultation sooner. But get a consultation if your son or daughter isn't getting better. Once a month is a fairly limited amount of contact. It's hard for somebody who sees a borderline patient that frequently to do much more than oversee their medications. And I can't say that if the person is also a wise counselor and that the patient looks up to them, that can't be quite helpful. But for the most part, the treatment of this disorder is around once a week, and the person needs to be part of their life so that they become a resource that both the patient and the family can turn to.
Okay, good. So another person asks about any advice of dealing with a spouse who has borderline personality disorder. This person describes episodes where she'll go, quote unquote, catastrophic, and the relationship is on the line because I asked her not to micromanage me doing the dishes. And to her, that was the equivalent of asking her to not be herself, and therefore she laid the marriage on the line. Any advice on how to de-escalate those types of situations?
Well, there's a simple answer to that one. That may not be a marriage you want to stay in, but insofar as that question arises out of a concern for the wife's welfare, I would encourage the fellow to start with seeing whether she'll go into couples work, rather than that telling her that she's got a disorder for which she needs treatment. She does not sound like she has that kind of self-awareness and would only view that message as further evidence of how misunderstood and insensitive the husband is. It's a very complicated thing because I get a lot of communications over the years from spouses who are sure that their spouse has borderline personality disorder. What they have is a very bad marriage. And what they use that diagnosis as a way to sort of see the spouse's problems in the marriage rather than their own. Now, I'm not saying that sometimes it isn't because you have a spouse who's got that disorder, but whether you do or you don't, the best approach is we've got a problem, and we need help because I can't handle this. It's too hard on me. Not because you are a difficult person, but it's too hard on me. I have limits about what I can deal with. So you take it from that point of view, and then see whether you can get into a couples work.
Great. A couple of people, I'm seeing follow-up questions to your comment a little bit ago about if you feel that the person's not getting better, if you're worried that the treatment they're in isn't appropriate, to get a consultation. And a couple of people have asked, what do you mean get a consultation? I think a lot of these people are family members of adults with borderline personality disorder. And so what does that mean?
Well, I'm not sure where the adult comes in, but if you're the parents of a offspring who doesn't want to participate in the consultation, you get the consultation for yourself. And if you have, as the example we heard about a few minutes ago, an offspring who's not making any progress, then you get the consultation with the kid involved, of course. But there are certain things which should happen in the natural course of this disorder, which is that self-harm should generally diminish if a person's in active treatment. That's having an effect. The lability and the depth of their anxiety and depression should diminish. And those are things you should see in the first few months. It doesn't mean that if it doesn't happen in the first few months that it's a bad treatment, but you should worry about it. If the patient in this instance has continued dissociation, and I can't remember whatever else it was, that's another symptom which one might expect to diminish. Some of the symptoms of the disorder will improve more slowly. Self-harm, angry outbursts are amongst the first to diminish. Intolerance of being alone, abandonment fears, those are slower to diminish. So in general, you see the behavioral problems are the earliest to diminish, the emotional problems second to diminish, and the interpersonal problems third to diminish. That's a generalization. But you should look for progress. It's not something that you wait for 2 years or even a year without looking for signs of progress. Even 6 months.
Great. Several people have asked the question about what causes borderline personality disorder. Is it environmental, heredity, trauma-related experiences?
Yes.
Why are more women than men affected?
Yeah. There are an equal number of men as women. I'm amongst those people who perpetuated the idea it was primarily female because that's what we always saw clinically. But when you went into community sampling, there's equal numbers of males. And partly on account of that, we're about to open a new treatment center for males. We've had treatment center for females, but now we're going to open one for males. Anyway, what causes it? There's a genetic basis for this, which accounts for about 55% of the variance. So that's a complicated concept. So let me say a little bit about it. It doesn't mean it's a genetic disorder. It means that and it doesn't mean that it's always 55%. That's an average amount of the causation from genes. It means in some kids it's going to be up to 70%, and others it's going to be down to 40%. And so there's an inverse relationship. The more genetic loading you have for this disorder, the less environmental adversity will be required to develop it. The lower the amount of genetic loading you have for the disorder, the more environmental adversity is that's required to develop it. The question about trauma, about 70% of people with this disorder will report that they've had childhood trauma. When that first came out in the 1980s, it was thought, well, maybe this is a variation of post-traumatic stress disorder. At that time, we didn't know what we know now about that. There's a lot of people, the majority of people who have childhood trauma don't go on to have any psychiatric sequelae at all. About 1 in 4, something like that. And those who do develop psychiatric problems, it's not primarily borderline personality disorder. This is something that is found in equal percentages amongst people with other psychiatric disorders. Certainly, many of the personality disorders and other major psychiatric disorders have a high frequency of childhood trauma in their backgrounds also. So I don't want to minimize it, but when I said that 55% of the causation for this disorder comes out of genes, as a global mean or average, it's about 15% of the causation which comes out of childhood trauma. Doesn't mean it's 15% for everybody. It means it could be 40% for some and 0% for many. So it's neither necessary nor sufficient.
So, Doctor, I want to ask you a controversial question that a lot of people struggle with. So we have a lot of parents of people with BPD on our webinar. And obviously these people are logging into our webinar. They're concerned, they want information, they want help. There must be something good about them. And yet some of them have had a child with borderline personality disorder accuse a specific family member of doing something so horrible that caused their suffering. And they can't seem to get off that topic. They stay focused on, well, if Dad hadn't done this to me when I was a child, I wouldn't be the way I am. What advice do you have for those family members dealing with this kind of chronic agony when the family members swear up and down, we never did anything that was abusive?
Well, that's a very complicated and very unusual problem. That is, it is not uncommon for people with borderline personality disorder to fix on their families as having mistreated them in a variety of ways, whether it's traumatic, what we call trauma or not, and say that that's the reason they developed the disorder. And to become quite fixated on that and have a very hard time giving it up. The first thing which needs to be done, and it needs to be done insistently and repeatedly, has to do with psychoeducation. It is not sufficient to say your parents caused your disorder. They may have been very dysfunctional in their parenting of you. But you cannot overlook the way we used to, the way I as a clinician used to, the fact that you came into this world with difficulties which were going to make you difficult to parent. You were a difficult child. And if you had had super parents, you may never have developed the disorder. If you had average parents, you might have developed the disorder, but not so severe. But if you had parents who had some of the same traits you have, so that you're extremely reactive, extremely hypersensitive to any signs of anger or rejection, they're going to compound the problems that you brought into the world. They're no more guilty than you are when you lose your temper. That is, it's a interaction of things where you bring out the worst in them and they bring out the worst in you. That's a model which you have to repeat over and over again, because it is very easy for people with this disorder and their parents to quickly slide into either or. Either the parents oftentimes will be overwhelmed with guilt and assume when their parents, because they know the kid's never been happy with them, has always been accusing them of having failed, that they've taken this on, we wished we could do anything. And then those are parents who oftentimes end up, selling the house in order to pay for the treatment. And but the other way is that they get very hostile and say, you're blaming me and you were just a difficult child. And so it's easy to split this into bad child, bad parents, and you want both sides of that equation to get their heads around the idea of this interactional thing.
So
what do you think of the notion of pointing out that maybe you were born a more sensitive
Absolutely.
child than
absolutely.
others? And
I even go so far as and many borderline patients don't like this originally, but then they see there are some dividends in it, that you're a special needs child. And that the family, what we ask, the reason we want to involve your family is we want to customize the parenting for you. That your parents are doing what they think is the best thing. It's not the best thing. It's far from the best thing. They need coaching.
But so instead of using the language that you might have been a difficult child to parent, which is what you said, and I'm sure a lot of parents are thinking that, maybe if when the parent's actually having this conversation with the child, to say that it was really hard to parent you because you seemed more sensitive and emotional than other people.
I have no apologies for my first one. Both are there. Both are there.
Yeah.
And I oftentimes want the people with this disorder, the ones who are so insistent, especially those who are most insistent upon how their parents caused all their problems. I really get in their face about, you are a difficult person and you were a difficult child, I have no doubt about it. And this is one of the great frontiers of research, is we are working to identify the kids who are at risk for the development of this, so that we might customize the home environments at a much earlier age than after the disorder has developed.
Wonderful.
So with that, it is a little bit past 5 o'clock, so we're going to have to end. I want to thank you so much, Dr. Gunderson. It's been very helpful and insightful. Thanks so much.